Okay, so today I'm going to be talking to you about intra-aortic balloon pumps and what the intensive care physician really needs to know. So initially, I'll talk about the concept of how balloon pumps work, the components of a balloon pump, the indications for using an intra-aortic balloon pump. I'll talk about the complications. I'll talk about the technical aspects. How do you know that the balloon pump is actually doing what it's supposed to? How do you know that it's working? And then I'll talk briefly about weaning. So what is the concept of using a balloon pump? The concept is that it inflates in diastole, and then it deflates at the onset of systole. When it inflates in diastole, that achieves a very important increase in the mean arterial pressure, because the mean arterial pressure mainly depends on your diastolic pressure. And so that inflation increases your mean, and so it increases systemic perfusion. But also that increase in diastolic pressure will increase your coronary perfusion. And so inflation in diastole increases your mean and increases your coronary perfusion. That deflation at the onset of systole creates a bit of a vacuum effect. And all of a sudden, as the heart starts to beat forward, you get a deflation. That vacuum effect reduces your afterload. The components of a balloon pump is that it's a flexible catheter with two lumens. The distal lumen is the lumen that you can transduce, that you can measure pressures through. You can flush that distal lumen as well. And then there's an inflation-deflation lumen that comes in different sizes. And the gas that it inflates and deflates is helium. Why helium? Because it has the lowest density possible. It's easy for helium to go in and out of the balloon at very quick speeds. Any other gas would have a higher density. It would be more tough to push the gas in and out that quickly. And then there's a mobile console, which controls that inflation, deflation, and controls how much augmentation you want to provide. So what are the inflation triggers that you can use for a balloon pump? How does the balloon pump know that it needs to inflate? There are 5 different triggers that you can set the machine to. ECG tends to be the most common trigger that we use, but it could also be set to trigger with pressure. As soon as it detects or the diastolic downstroke, it means that's the onset of diastole. That's when it inflates. You can also set it to be triggered by the ventricular spike in cases of VVI pacing. You can also set it to be triggered by the R wave if you're only pacing the atrium. And you can set it to internal, which is just a fixed rate. So which of these do we use? By default, most of the time, we use the ECG trigger. Are there other situations where we would use other triggers? Yes, there are. So say you have a patient in the cardiac surgery ICU who arrests, for example. During a code blue in the CS ICU, you'll start chest compressions. The ECG will not be reliable. And so in the middle of a code blue, if somebody has a balloon pump, set it to pressure. And that way it knows to augment during diastole instead of an ECG, which will at the time would be non-reliable. So during CPR, set it to trigger with pressure. When do you use internal? Use internal if there's a significant pause in chest compressions in the middle of a code blue. So say, for example, you're going to pause chest compressions because the surgeons are going to clean up the chest and they're going to open the sternum. So during that time that you're pausing CPR, you can set it to internal to provide the patient with some forward flow while you're pausing CPR, or while they're scrubbing the chest to open the chest to get an early sternotomy done. So default, it'll be ECG. As I said, during a code blue, it'll be pressure. During a pause in chest compressions, it'll be internal. So what about auto? Nowadays, we see set to auto most of the time. And what auto does, it basically looks at both ECG and pressure, and it takes input into a software algorithm and gives you proper timing based on the input from both the ECG and the pressure. So auto has actually fixed a lot of our problems. You don't really need to worry too much about timing with auto. Most of the times, I'd say 95% of the time, it's inflating at the correct timing, deflating at the correct timing if you set it to auto. What are the indications of an intra-aortic balloon pump? So in our world, the indications include cardiogenic shock, especially when you're refractory to 2 or more vasopressors. Low cardiac output post-bypass if they're unable to wean from cardiopulmonary bypass. If you have a mechanical complication of acute myocardial infarction, like an acute ischemic MR due to papillary muscle rupture, and a post-MI VSD. Both of these are mechanical complications of acute MI that benefit hugely from balloon pumps. And then the last is intractable cardiac ischemia. If you have somebody with left main disease who's pending surgery, if you have somebody who has a high-risk angioplasty. We've had a lot of trouble demonstrating that balloon pumps actually improve outcome. Most of the studies that we've come that have been published have not shown that balloon pumps actually improve outcomes, but we still use them. They make physiologic sense in a lot of these cases, and we see an improvement in our parameters, but it is on a case-by-case basis. So what do balloon pumps do? Balloon pumps basically reduce, they increase your mean arterial pressure, so that's their beneficial effect, but they actually reduce systolic pressure. They reduce your systolic pressure by at least 20%. They increase your diastolic pressure by more than 30%, and that's how they increase your mean. And they also increase your cardiac output. That vacuum effect reduces the afterload, and you get a push of blood out into the systemic circulation because of that vacuum effect. And so balloon pumps increase your cardiac output by about 20%. And with that increase in cardiac output, you will sometimes get a drop in heart rate. So how do you quantify the increase in cardiac output? So that increase in cardiac output with balloon pumps is actually quite mild. At the most, you will get an increase in cardiac output of 0.5 to 1 liter per minute. Now remember, cardiac output can be anywhere from 5 to 8 liters per minute. That extra push that you're getting from a balloon pump is only half a liter, up to 1 liter per minute at the most. So if you have somebody who's in profound shock and you feel like he'll need more support than a balloon pump, then by all means, you should go to something like an Impella or even VA ECMO if it's indicated, where you can provide flows of 5 liters or 5.5 liters. Balloon pumps only give you an increase in forward flow of about 0.5 to 1 liter per minute, and that's it. So how do you know that a balloon pump is working? So a balloon pump augments your diastolic pressure. So you'll see here that there is a peak due to the augmented diastolic, and that peak is higher than the native systolic pressure. And then it deflates, and that deflation creates an aortic end diastolic pressure that is very low, and that's how it reduces your afterload by that vacuum effect, and that sudden deflation leads to a reduced aortic end diastolic pressure. That aortic end diastolic pressure after the deflation will actually be lower than the native diastolic pressure. And that's the native diastolic pressure is highlighted in blue here. You see here that the aortic end diastolic pressure is lower due to the vacuum effect, due to the afterload reduction. And then the next systolic upstroke will actually be lower than your native systolic peak. So you see here that balloon pumps reduce your systolic blood pressure, but they increase your diastolic and increase your mean. So when you're at the bedside and trying to understand whether this balloon pump is actually doing what it's supposed to, whether it's actually working or not, you have 3 parameters to look at that will tell you that the balloon pump is augmenting well and it's doing what it's supposed to. What are these 3 parameters? The first parameter is that you see that the augmented diastolic pressure, that peak of augmentation, is higher than your systolic pressure. So the augmented diastolic, you will find, is greater than your systolic pressure. And that's the first sign that shows that the balloon pump is actually working. The second sign is, as we said, as the balloon deflates, you'll get a drop in diastolic pressure, and the aortic end diastolic pressure right after deflation, that point number E, will be lower than your native diastolic pressure. And that tells you that the balloon is giving you afterload reduction. The third parameter is that when you look at the systolic upstroke right after your augmentation, we call that the assisted systolic pressure, you will find that it is lower than your native systolic pressure. So the balloon pumps actually reduce your systolic pressure. Your augmented or assisted systolic pressure will be lower than your native systolic. So these are the 3 parameters at the bedside that will tell you that this balloon pump is augmenting and it is doing what it's supposed to. So let's look at this here. So you see here, we have the balloon on 1-to-1. And you see here that that augmentation, that peak, is higher than the systolic pressure. So here we can see very clearly that the augmentation, which is corresponding to that augmentation tracing, is higher than your systolic pressure. So you see here that it's very clear that there is one parameter that at least that is telling us that the balloon pump is doing what it's supposed to. There's an augmented diastolic that is higher than the systolic pressure. The next two parameters, you'll have to change the frequency of the balloon pump to 1 to 2. And then you will take a look at the tracing. And you'll also use the reference line to assess that aortic end diastolic pressure and to assess the assisted systolic pressure. So let's see how that works. We see that the balloon pump is augmenting well. That augmentation is higher than the systolic. But right after, let's see what happens right after that deflation of the balloon. Let's look at the aortic end diastolic pressure. So here we've used a reference line to see what the aortic end diastolic pressure looks like. So here, right after deflation, there's an aortic end diastolic pressure that is lower than your native diastolic pressure. So let's look at these here. You see an aortic end diastolic that is actually lower than your native diastolic. So that's parameter number 2. That tells me the balloon pump is working well. I put it 1 to 2. I used my reference line. I looked at the aortic end diastolic pressure right after augmentation, and it's lower than my native diastolic pressure. Let's look at parameter number 3. You've moved your reference line up to the systole now to see how your augmented systolic compares to the native systolic. And it's very clear here, very clear, that the systolic right after the augmentation is lower than the native systolic. So here it's very clear. This is the native systolic. We have the reference line on the native systolic. The systolic right after augmentation is lower. So that tells me by all 3 parameters, this balloon pump is working very well. So now we have a balloon pump that's working by all 3 criteria. Now memorize these criteria very well. Use them at the bedside. Go to the bedside. Put it on 1-to-1 initially and see if the augmentation of the diastolic pressure is higher than your systolic, and then put it 1 to 2. Look at the aortic end diastolic pressure, make sure it's lower than your native diastolic pressure, and then use the reference line to go and assess systole. You'll see the assisted systolic pressure will be lower than the native systolic pressure. So these are the 3 parameters. Let's move on to the contraindications. So the 2 absolute contraindications are anything greater than mild aortic regurgitation, anything greater than mild. So if you have moderate or severe aortic regurgitation, balloon pumps will make your aortic incompetence worse. They will make your regurgitant jet worse because they will inflate in diastole. They will force blood back into the LV during diastole. They will worsen aortic regurgitation. So moderate to severe aortic regurgitation are both absolute contraindications. Aortic dissection is also an absolute contraindication because your balloon pump may track up to the false lumen. It may worsen your dissection. So these are the 2 absolute contraindications. The others are relative contraindications. These include uncontrolled sepsis, uncontrolled bleeding tendency, and severe peripheral vascular disease, because you'll have a tough time putting the balloon pump in the common femoral artery if they have severe peripheral vascular disease. So what are the potential insertion sites? We have 3 potential insertion sites. One, which is the most common, and that is a femoral artery insertion site. You put it in the common femoral artery, and you basically thread it upwards, up the descending aorta. And that is the classic approach. However, sometimes in the OR, when you have somebody coming out with an open chest, sometimes we see surgeons who have put in a balloon pump centrally. And what do I mean by centrally? They've actually punctured the distal arch and the start of the descending aorta. They've punctured it in the OR, and then they've thread the balloon pump downwards. Okay, so that is a central approach. What is the problem with that approach? The problem is you have to go back to the OR to take the balloon pump out. It cannot be taken out at the bedside. They'll likely come out with an open chest with a balloon pump that is central in location. When they go back for chest closure, that is the time where they'll have to take the balloon pump out because you'll need to expose the descending aorta to remove it. The last approach is the axillary approach, and that can be put in the cath lab. We have some cardiologists who are comfortable with that approach. They basically puncture the axillary artery, and then they go backwards into the descending aorta, and that is both of these approaches, the central and the axillary approach. The marker, or the radiopaque marker, will actually be lower down in the descending aorta. It will not be higher up. as we will see. So what is the advantage of an auxiliary balloon pump? The advantage is ambulation. So this is a gentleman with an auxiliary balloon pump, and they can actually ambulate with an auxiliary balloon pump in place. If they've got a femoral balloon pump, they will not be able to ambulate. Obviously, if it's central, they will not be able to ambulate as well. So that is the advantage of an auxiliary balloon pump. It takes a little bit of technical expertise, and not all cardiologists are comfortable putting in auxiliary balloon pumps. How do you confirm position? So initially, before putting a balloon pump in, we measure the distance from the common femoral artery up to the umbilicus, and then from the umbilicus up to the sternal angle. And that gives us a rough idea how deep our balloon pump needs to go, just by surface landmarks before we put the balloon pump in. We try to puncture the common femoral artery. Don't go lower down. If you go lower down, then you're risk at complications, including ischemia. So try to puncture at the level of the common femoral artery. And then, once you're done, confirm that the balloon pump tip is in the right spot by getting an X-ray or by TEE. So on X-ray, you should see that radio opaque tip here is about 1 centimeter or 2 centimeters above the left mainstem bronchus, or roughly at the level of the carina. So basically, where do you want that tip to be? You want it right after the takeoff of the left subclavian artery. So the left subclavian artery here is at the end of the arch of the aorta. You want the tip to be right below, or 1 centimeter below, the takeoff of the left subclavian artery. In the descending aorta, right after the subclavian takeoff, or 1 centimeter after the subclavian takeoff. That radio opaque tip tells me I'm in the right spot. As I said, 2 centimeters above the left mainstem bronchus, or at the level of the carina. You can also make sure that you're in the right spot by TEE. So here we see up top that this is the descending aorta. We see the tip of the balloon pump. I pull out my TEE machine, my TEE probe, and I start seeing the subclavian artery. So here's the tip. I'm right here. I pull out. I no longer see tip, and I see subclavian artery. That tells me that the tip is in the right spot. So TEE is very helpful in showing you that the tip is in the right spot as well. So, as I said, the radio opaque tip will be up in the descending aorta only with femoral insertion. If you're putting it through the axillary approach, you'll use fluoroscopy. If you're putting it through a central approach, the radio opaque tip will be tunneled down. It will not be up. But by default, because you're putting it under vision, it will likely be in a good spot, unless you're putting in a really big size for a small patient. But as I said, you really don't need to see the radio opaque tip if you've put it centrally, because you've punctured it right at the right spot under vision in the OR. So you don't need that, and you will not see that radio opaque tip if it's central in placement. Okay, so what about complications? So there are vascular complications and there are non-vascular complications. The vascular complications include limb and visceral ischemia. If the balloon pump is too low in its insertion, it may encroach on the renal artery takeoff in the descending aorta, in which case you may start seeing compromise of the renal circulation. And that's why you don't want the balloon pump to be too low. You want it to be just right. Or you can get also peripheral embolization if you start developing clot on the balloon pump. Vascular laceration, pseudoaneurysms are common complications as well. Major hemorrhage at the site of insertion is a complication that you can see as well. Non-vascular complications include complications like sepsis, like any line you put in a patient. Any line that stays in for too long can give you sepsis. Thrombocytopenia tends to be very common with balloon pumps. Most of our patients, over time, you'll start to see a drop in their platelet count because of consumption. So cerebrovascular accidents can happen, and the usual cause of CVAs is that excessive flushing, or if your balloon pump is too high up, and you keep flushing, and you embolize air into the carotids. There have been case reports of strokes with balloon pumps related likely to the tip being too high in location and encroaching on the carotid arteries. Again, so what I want you to take from this presentation is, how do you assess the balloon pump is working at the bedside? We mentioned you assess the augmented diastolic and you make sure it's greater than the systolic on 1-to-1. You go to 1 to 2, and then you adjust the reference line. You make sure your assisted end diastolic pressure is lower than your native diastolic pressure, right here, and that your assisted systolic pressure is lower than your native systolic pressure. Okay, so let's move on. Timing. How do you assess timing of a balloon pump? We mentioned that when you put it on auto, 95% of the time, it will get the correct timing by looking at both the ECG and the pressure tracing. But you can tell by looking at this waveform here that this balloon pump is inflating a bit too early. It should inflate right after the aortic valve closes when you see the diacrotic notch. So you should start seeing the downstroke and then the balloon pump inflates. This balloon pump is inflating too early. And so this is early inflation. So what happens when a balloon pump inflates too early? You will cause premature aortic valve closure, because when you increase the aortic pressure with that inflation of the balloon pump, that aortic pressure, that sudden rise in aortic pressure, will lead to premature closure of the aortic valve. So you will step on systole. Essentially, they call this you're stepping on systole, because the ventricle was still contracting, the aortic valve was still open, and then you inflated your balloon too early, and then you caused premature closure of the aortic valve, and you stepped on systole. You abruptly ended systole before it should have ended. And when you do that, you increase your afterload. You reduce your cardiac output. You've reduced your systolic time. You will increase your left ventricular end diastolic volume, because now you've cut short systole and the ventricle has not fully emptied. And so you'll find an increase in left ventricular end diastolic volume, an increase in left ventricular end diastolic pressure, increased wall stress on that LV, and increased myocardial oxygen demand. So early inflation is detrimental. Early inflation is harmful. What about this tracing here? When you look at this tracing here, you see that there is systole and there is the downstroke. There's the diacrotic notch. The balloon pump should have inflated on the diacrotic notch, but it did not. It waited, and then it inflated later. So this is late inflation. It's not inflating where it's supposed to. What happens when you have a balloon that is inflating too late? You don't get the benefit from the balloon pump. I must say, it's not totally harmful, but you're not getting the benefit. You will not get optimal diastolic augmentation, because now, instead of augmenting throughout this entire diastole, you're augmenting very late in diastole. And so you don't have a lot of time here. And so the balloon pump will not augment the entire diastole. You'll get suboptimal diastolic augmentation. You've got suboptimal augmentation of the coronaries. So late inflation leads to a loss of benefit. It's not totally harmful, but you don't get the benefit of a balloon pump if it's inflating late. When you look at this tracing here, you see a balloon pump that is inflating at the diacrotic notch. That's great inflation timing. But then it deflates, and there's still a lot of diastolic time. So it should deflate as soon as systole starts. Here, it's deflating in mid-diastole. It's deflating very early. So with early deflation, what you see here is usually suboptimal diastolic augmentation, because you're not using the entire diastolic time to augment your diastolic pressure and your mean pressure. So you don't get good diastolic augmentation. You get suboptimal afterload reduction. Why is that? Is because you've used your vacuum effect too early. The ideal time for deflation and getting that vacuum effect is at the onset of systole, and your vacuum effect is too early. It's not happening at the onset of systole. And then your assisted systolic may start rising. You'll see that the assisted systolic here is not lower than your native systolic, because you're not really getting an afterload reduction. So another potential theoretical concern is that early vacuum effect can lead to potential retrograde and coronary and carotid flow, and the potential for angina. This, however, is a bit of a theoretical concern. What about this tracing here? You see that it's inflating at the correct timing, right at the diacrotic notch. It's augmenting very well, but then it's deflating quite late. And you can see here that with late deflation, what will happen is the balloon pump will remain open, and the ventricle is trying to contract against a balloon pump that's inflated. So you're increasing the work of the ventricle because the balloon pump remains inflated during systole here, because it's not deflating at the proper timing. It's deflating more late. So the LV will be ejecting against greater resistance because your balloon pump is still inflated. You'll get a prolonged isovolumetric contraction phase. You'll get an impedance of left ventricular ejection fraction, an increase in afterload, because now your balloon pump is inflated during systole. And your assisted aortic end diastolic pressure may be equal to your unassisted aortic end diastolic pressure. You can see here that if you put a line, this end diastolic pressure right after deflation should be lower than your native diastolic. Here, it's actually high because your balloon pump is still inflated. And that's why your end diastolic pressure will be equal to or even sometimes higher than your native diastolic pressure. This tells you that the balloon is deflating late. All right, so let's go back to our indications. And I want to go through some of the evidence with regards to these indications. As I mentioned previously, we've had a hard time showing that balloon pumps actually give you an improvement in mortality. We've had a very hard time showing this. So let's start off with the most significant publication regarding balloon pumps, and that is the Intraaortic balloon pump shock 2 trial. And this was published in 2012. It was a multi-center randomized control trial in Germany. And they randomized patients with acute myocardial infarction complicated by cardiogenic shock with planned early revascularization. They randomized them to either getting a balloon pump or not getting a balloon pump. So here, this is a relatively large study. They had a total of 600 patients, and all of these patients presented with cardiogenic shock because of an acute MI, and all of them had planned early revascularization. And they excluded patients with mechanical complication of cardiogenic shock. And what I mean by that is somebody with ischemic MR or ischemic VSDs were excluded from the study. They also excluded patients with poor prognosis. If they had CPR for more than 30 minutes, if they have fixed pupils and were in coma, no intrinsic heart action, their shock was more than 12 hours ago in its onset, if they had a massive PE, if they were too old, or if they had a contraindication to balloon pumps. And what they looked at was 30-day all-cause mortality, and their secondary outcomes were major bleeding, peripheral ischemic complications, sepsis, and strokes. So what did they find? They found that the mortality was no different. At 30 days, the control group that did not get a balloon pump did the same as those in the intervention group that got a balloon pump. There was no difference in mortality at 30 days between both. There was a crossover rate in the study. In the intervention group, 13 patients actually did not get a balloon pump in the intervention group because most of them actually did too poorly, or they arrested or passed away before they got a chance to get a balloon pump. And there was, in the control group, 30 patients actually ended up getting a balloon pump based on the physician preference. So there was a bit of a crossover, but it was not that significant. Nonetheless, there was no difference in mortality. And there was also no difference in complications. Surprisingly, they did not find a difference in any of the even ischemic complications or bleeding complications from the balloon pump. So what they concluded was that in patients with acute MI complicated by cardiogenic shock with planned early revascularizations, balloon pump did not improve 30-day mortality. So the use of a balloon pump did not result in any significant increase in complications. That was another finding that they found. So that was the IABP shock 2 trial. And since this trial came out, balloon pumps in the setting of cardiogenic shock and acute MI moved from category 1 indication to a category 2 potential indication. So it's a case-by-case basis. It's not now it basically moved down the recommendations. They also followed these patients up 6 years after the study. That same study, that same authors, they looked at patients after 6 years from getting the balloon pump. And what they found that there was no difference in 6-year mortality between those who got a balloon pump and the control group. And there was no difference in recurrent MIs, strokes, repeat revascularization, or rehospitalization for cardiac reasons. So 6 years out, there was no difference between those who got a balloon pump and those who did not. And even the survivor's quality of life was no different between those who got a balloon pump and those who did not. So this was the IABP shock 2 trial, and it was a negative study. So let's go back to the indications. We said cardiogenic shock on a case-by-case basis. We don't have strong evidence that it actually improves mortality in that situation. But what about mechanical complications of acute MI? So we spoke about acute ischemic mitral regurgitation due to pap muscle rupture and post-MI VSD. Why do you think a balloon pump would help patients with acute ischemic MR? And why would it help patients with post-MI VSDs? The concept is very simple. The balloon will deflate at the onset of systole. So it will create a vacuum effect. It will reduce your afterload. It will encourage forward flow up the ascending aorta. Now remember here, let's think about it together. Patients with acute severe MR, blood can go in one of two directions. Blood can go back into the left atrium because of the severe MR, or blood can go forward through the aorta. Which is lower in pressure? The atrium is lower than in pressure. So blood will favor going backwards from the ventricle into the atrium in severe MR. So if you reduce the systemic afterload, you will improve forward flow. You will encourage blood to go forward into the aorta instead of going backward into the atrium. The same applies to VSDs. When you look at the pathophysiology of ischemic VSDs, blood is shunting from the left ventricle to the right ventricle. When you put a balloon pump in, you reduce your afterload, you encourage flow from the left ventricle up into the aorta. And so you reduce the magnitude of shunting to the right side with ischemic VSDs. And I must say, if there's two indications that you really should remember to think of a balloon pump with, it's these two indications, because you will see a huge difference in hemodynamics once you put a balloon pump in somebody with acute ischemic MR due to a ruptured pap muscle and acute ischemic VSDs. I've seen patients where a balloon pump makes a huge difference in these patients, and it's just like night and day. And so where did we get this from? So this is a publication that was very old, in 1973. They looked at balloon pumps with ischemic VSDs and ischemic MR, and they published this in Circulation, and all they had was 11 patients. And back in 1973, you could publish in Circulation with only 11 patients. They used a balloon pump in 5 patients with ischemic VSDs and in 6 patients with ischemic acute MR. And they found that the balloon pump increased their mean, improved their cardiac output, reduced their wedge pressure, and in patients with VSDs, it reduced the magnitude of shunting. So it really made a huge difference. And I must say, in clinical practice, we see that it makes a difference in these patients. And they concluded that coronary angiography can be performed safely in these patients once you support them with a balloon pump. So remember these two indications, acute ischemic MR and ischemic VSDs. So let's go back to our list of indications here. So we mentioned intractable cardiac ischemia. We mentioned left main disease pending surgery, adjunct to high-risk angioplasty. There's been a study that was recently done with high-risk angioplasty, and it did not show a difference whether you put a balloon pump in or not. So it's really a case-by-case basis. And then when you have somebody with left main disease, this study here tried to prove the benefit, but they failed. This study did not show a benefit from putting in a preoperative balloon pump for somebody with left main disease. This was a retrospective cohort study of 588 patients who received a balloon pump pre-op before going to the OR. Some of them were not left main disease. Some of them were just put in prophylactically. It was felt that it was a high-risk patient. Some of them had unstable or crescendo angina, and some of them had rapiding worsening of hemodynamics. And so what they found was, according to the indication for putting in the balloon pump preoperatively, the mortality was very different. So obviously those who got it prophylactically are the ones with the green line. They had the lowest mortality. The ones with unstable angina, the blue line, had a bit of a worse mortality. And the ones with worsening hemodynamics had a bit of a even worse mortality. But what they did also is that they looked at complication rates from balloon pump. They said the complication rate is about 7%. And if a patient is a current smoker, or if you use a 9 French catheter, this predicted vascular complications. Obviously, a bigger catheter is associated with a higher complication rate. But what they did is they did a propensity match score of 74 patients who received a balloon pump for severe left main disease. And they compared these 74 patients to a propensity matched group of patients who did not receive a balloon pump for left main disease. And what they found was that there was no difference in outcomes post-surgery for the pairs of patients who had balloon pumps versus no balloon pumps for left main. So what they concluded was that left main disease is not itself a sufficient indication for prophylactic balloon pumps. And they said preoperatively, the use of balloon pumps in cardiac surgery was shown to be safe even for the high-risk patients. So this was a retrospective cohort study. It was not a randomized controlled trial. So one of the very few publications that actually have shown a benefit of using preoperative balloon pumps is this meta-analysis here that was published in 2017, where they looked at, they basically did a meta-analysis of a total of 9,212 patients who received a balloon pump preoperatively prior to going for CABG. And they found, when they put together these 9,000 patients, that the mortality favored a balloon pump. So they had less mortality with pre-op balloon pumps, those going for high-risk CABG. And the cardiac output, having symptoms of low cardiac output, was less in those who got a balloon pump. So you improve, obviously, cardiac output with a balloon pump. So there was a benefit here in this publication on mortality and in improving cardiac output, but there was no other benefit really to balloon pumps in this publication. So back to our list of indications. So this list of indications is on a case-by-case basis. I want you to memorize them, but I want you to know that the two that are really very important are the ones with acute ischemic MR and acute post-MI VSDs. We still use them for patients who are not able to come off pump. If you have low cardiac output post-bypass, we put them in. But as I said, they only provide you with 500 mils to 1 liter of forward flow. So if you feel like the ventricle is failing enough that a balloon pump will not suffice, then you may need to put something more aggressive like VA ECMO or an Impella. For intractable cardiac ischemia, they're still used in the cath lab a lot of times by our cardiology colleagues. However, we have not had a lot of luck proving with RCT data that they actually improve mortality. But physiologically, they make sense. We see the improvement a lot of times at the bedside, and that's why it's probably still used. So do we anticoagulate patients with a balloon pump? So there's no real consensus on anticoagulation management. Some of the observational data suggests that anticoagulation may be beneficial, but there's no high-quality RCT evidence to guide us with regards to anticoagulation. The potential benefit of anticoagulation is the reduction of limb ischemia and the reduction of thrombosis related to the balloon pump. The potential risks include worsening bleeding from the access site, from the insertion site. And so this meta-analysis of observational data showed that patients who got anticoagulated with balloon pumps did not have any increase in major access site bleeding, and they did not have any increase in minor access site bleeding. So bleeding did not seem to be a huge risk when you anticoagulate somebody with a balloon pump. And what they found when it comes to limb ischemia in this meta-analysis, they found that there may be a benefit from anticoagulation in preventing limb ischemia. And there may be a benefit with in-hospital mortality. But you can see here, there's not a lot of studies, and it's all observational data. It's not RCT data. And so you can take this result with a grain of salt. So do we anticoagulate, do we not? The decision to anticoagulate and the intensity of anticoagulation depends on the thrombotic risk and the bleeding risk. If they're high risk for bleeding, like in the post-op settings, we usually will not anticoagulate therapeutically. If there is a thrombotic risk that is huge, if they're in the cath lab, if they're getting an angioplasty, then anticoagulation is likely going to be indicated. So the step-by-step management guidelines of short-term MCS that were published in 2023, last year, by the European Society of Cardiology, they say the decision to anticoagulate and the intensity of anticoagulation depends on thrombotic and bleeding risks. They don't make a recommendation one way or the other. But I must say, if you work in the cardiac surgery ICU, most of the times we don't anticoagulate these patients because they're post-op and they're at risk for bleeding. So most of the times we will not therapeutically anticoagulate patients in the cardiac surgery ICU. However, if you work in the CCU, most of these patients are anticoagulated, and they have other indications also to be anticoagulated in the CCU. If they presented with an acute MI or they've got stents put in, then they will have other indications for it as well. So it depends on which location you work in hospital. And so what about weaning? Last but not least, how do you wean a balloon pump? There's also no consensus about how you wean. There are different protocols that have been published. The two major protocols are either ratio weaning or volume weaning. You can either reduce the frequency or reduce the ratio, go from 1 to 1 to 1 to 2, and then go to 1 to 3, or you can reduce the volume of augmentation, go down on the augmentation, and see if the hemodynamics tolerate. Now, you wouldn't wean somebody if they're on maximum inotropes. You need to have somebody who's at least on minimal, who is at least either off inotropes or on minimal doses of inotropes. Do not wean somebody, they're not ready to be weaned if their inotrope doses are high. They have to be either off or at minimal doses. What we do in our practice is that we do periodic ratio reduction. We reduce the frequency from 1 to 1 to 1 to 2, and then reduce it from 1 to 3, and then reassess the patient on 1 to 3 after 2 or 3 hours, see if their urine output's maintained, if their hemodynamics are maintained, if their inotropic requirements did not go up, if their lactate stayed stable, and if they're stable on 1 to 3, that tells us that they're likely ready to be weaned. Why do we like ratio reduction? Why don't I like the augmentation? It's because I'm really scared of, to be honest, thrombosis on that catheter. That's a foreign body in the aorta that can thrombose. If you leave it with very little augmentation, it can thrombose, it can collect clot around it. If you leave it on 1 to 3 for very prolonged periods of time, that's another setup for clotting on the balloon pump. So that's why when I'm assessing whether a balloon pump can come out, I put it on 1 to 3 for 2-3 hours at the most. And if the patient's ready, everything looks stable on 1 to 3, I will put it back to 1 to 1 until it's ready to come out. Now we've done a test that it can come out. Until the time we're ready to actually pull the balloon pump out, I'll just temporarily put it on 1 to 1 so that it doesn't clot from around it. When prolonged use is anticipated, an auxiliary approach may be considered, and patients can ambulate, as I said, with that auxiliary approach. So with that, I will end my talk, and please let me know if you have any questions.